everybody, I'm Kim Orleck. I'm a physician assistant out of Atlanta, Georgia. I practice at Atlanta Gastroenterology Associates. I'm also the Senior Director of Advanced Practice Provider for United Digestive, and I'm also on the board of GAPP. I'm really excited to be here today to talk to you about the efficacy and safety profile and data on Tremfya or Guselkumab in moderate to severely active ulcerative colitis and moderate to severely active Crohn's disease. So first, I'm going to get started with ulcerative colitis, which we got the approval for GUS earlier in 2025. The QUASAR study is what led to the approval of GUS in ulcerative colitis. In this study, we looked at GUS compared to placebo. It's important to call out that the GUS induction dose in ulcerative colitis is 200 milligram IV at 0, 4, and 8 weeks. And then responders in this study were re-randomized to either GUS 200 milligrams every 4 weeks starting at week 12, or the second maintenance option of GUS 100 milligrams starting at week 16 every 8 weeks. Again, pointing out that we do have 2 dosing options for ulcerative colitis, and both of these were compared to placebo in the maintenance arm. In this trial, we saw that patients receiving GUS had a significant separation from placebo in regards to their symptomatic response, which with ulcerative colitis means their rectal bleeding and stool frequency scores as early as 1 week. So this is really exciting to see that patients can start to have symptomatic improvement that fast. When we look at their symptomatic response rates, it's 53% at week 4 and 72% at week 12, which compares to placebo response rates of 30 and 35% at weeks 4 and 12, respectively. As we look a little bit deeper at clinical remission rates with GUS and ulcerative colitis, at week 12, 23% were able to achieve clinical remission with GUS compared to 8% of placebo, a nice adjusted treatment difference of 15%. As a reminder, it's really important with ulcerative colitis that this clinical remission endpoints include stool frequency and rectal bleeding, so how the patient feels, but it also uses our objective marker of endoscopic response, where these patients get scoped and have endoscopic scores of 0 or 1. When we look at just endoscopic remission rates at week 12, where we're looking at an endoscopic score of 0, a significantly greater portion of patients achieve this with GUS at 15% compared with only 5% of placebo patients. As we look a little bit further into maintenance, because we know it's really important to see that these patients on GUS felt better faster and got into remission fast, but we also want to see the sustainability. And so when we look at clinical remission out to week 44, that was observed in 50% of patients receiving the 200 milligram sub-Q every 4 weeks, and in 45% of the patients who were receiving 100 milligram every 8 weeks versus 19% of placebo patients. Furthermore, when we look at those patients who did achieve clinical remission at 1 year, 67% of them were also in endoscopic remission, again, meeting an endoscopic subscore of 0. I also think it's really important that we have open label extension data from this QUASAR trial. And what this shows is the long-term sustainability of symptomatic response at 2 years. Here we see that 95% of those on monthly GUS sustained symptomatic remission at 2 years, and 91.9% of those on every 4-week dosing sustained a symptomatic response. 90% who were in endoscopic improvement at 1 year were also in endoscopic improvement at 2 years. This is really important because with certain IBD therapies, we really worry about the loss of response, both subjectively with symptoms, but also endoscopically. And when we look at this open label extension, it shows us positive sustainability throughout the 2 years. The last part relates to the safety profile with GUS and ulcerative colitis. And it's really great to see in the QUASAR study that the safety is consistent with that observed in other indications, with no new safety signals identified in the UC clinical studies. What we see is GUS is very well tolerated, with adverse event rates similar to or lower than placebo. Serious adverse events and discontinuations were also similar to or lower in the GUS groups in both induction and maintenance compared to placebo. When we do look at common adverse events that we want to discuss with patients, this included injection site reactions, upper respiratory tract infections, and arthralgias, again, consistent with safety profile for other indications. Thankfully, looking at things like malignancy rates, including skin cancer, this was lower in the GUS arm compared to the placebo arm. So my summary for ulcerative colitis, and this is very consistent with how we're seeing the ACG, American College of Gastroenterology, and AGA, American Gastroenterology Association guidelines be updated, is that I, in my clinical practice and in these guidelines, we recognize Guselkumab as an effective option for both induction and maintenance of remission in moderate to severe ulcerative colitis patients. I'm now going to transition over to Tremfya or GUS in Crohn's disease. And so as we look at the efficacy and safety of GUS in Crohn's, I'm going to start with GALAXY 2 and 3, both of which were treat-through study designs evaluating Tremfya IV induction, again, 200 milligrams at 0, 4, and 8 weeks. And then similar to with ulcerative colitis, we have the two approved maintenance options of 200 milligrams every 4 weeks or 100 milligrams every 8 weeks. Interestingly, in this study, we not only compared GUS to placebo, but also to ustekinumab FDA-approved dosing for Crohn's disease. It's important as we look at this study that about 50% of patients were prior naive patients and 50% were prior bio-exposed, including TNF and veto. So what we see in these GALAXY IV studies is a clinical response rate at week 12, and this is based on CDI score. So this is our Crohn's disease activity index score. And what we see is a clinical response at week 12 of 55% for the 200 milligram IV arm and 49% for the 100 milligram arm at week 12 compared to placebo rates of 12%. The clinical remission rates for Tremfya in GALAXY 2 at week 48 were 55% for the 200 milligram arm and 49% for the 100 milligram arm. This compares to placebo remission rates of just 12%. When we compare this to ustekinumab, Tremfya had higher endoscopic response, endoscopic remission, and deep remission rates at 48 weeks compared to ustekinumab. So this is really important because all of us in IBD know that ustekinumab is a really good drug, but here we did see Tremfya having higher endoscopic response, remission, and deep remission rates compared to ustekinumab. Furthermore, endoscopic response rates, when we look at it for Tremfya, were 53% compared to 37% for Stelara. Another big takeaway was efficacy was fairly consistent in both biologic-naïve and biologic-experienced populations, meaning we have great options to use this therapy in our Crohn's patients who are both naive and exposed. Now I'm going to take a minute and shift to the GRAVITY study. This study was the first study in Crohn's disease to demonstrate efficacy using a sub-Q induction dosing of an IL-23. This really gives us flexibility on administration for our patients with moderate to severe Crohn's. When we look at this study of sub-Q dosing of GUS, again, about 50% were naive patients and 50% were bio-exposed. So one important thing when we look at GRAVITY sub-Q is different than the IV loading dose of 200 milligrams is the loading dose is 400 milligrams of sub-Q Tremfya given at 0, 4, and 8 weeks. This is two 200 milligram subcutaneous doses given at the same time to equate to that 400 milligram dose. The thought behind this is the bioavailability of sub-Q is about 50% the bioavailability of IV. Hence the dose difference if you decide to put your patient on sub-Q Tremfya for Crohn's compared to IV at 200 milligrams. This study did look at Tremfya compared to placebo. And what we see is at week 12, clinical remission, again, looking for a CDI score less than 150, was achieved in 56% of patients receiving GUS or Tremfya every 4 weeks compared to 21% of placebo patients. Endoscopic response at 12 weeks was seen in 34% of those patients on GUS compared to only 15% of placebo. Similar to what we saw with GALAXY, the IV study in Crohn's, We saw in this study with sub-Q a rapid clinical response where 48% of the patients treated with GUS had a 100-point or greater drop in their CDI score at 4 weeks. Again, similar to ulcerative colitis, really seeing that fast clinical response. When we look at week 48, a little bit further out, we see clinical remission rates were 59% for the 100 milligram every 8-week group and 65% for the 200 milligram every 4-week maintenance arm, compared to 17% for placebo. When we look at endoscopic response in this Crohn's population at week 48, we saw 44.3 and 51.3% for the 2 GUS regimens versus 6.8% for placebo. Again, efficacy was very good and consistent and greater than placebo in both bio-naive and prior bio-exposed patients. Safety, of course, is very important. So again, when we look at adverse rates, this was not any higher in the Guselkumab arm compared to placebo arm. And the safety profile, again, was very consistent with what we've seen in other approved indications for GUS, with no new safety signals identified throughout the first 48 weeks. The most common adverse events were nasopharyngitis and upper respiratory tract infections, and serious adverse events were infrequent and similar across groups. In summary, we are really excited to have GUS in our armamentarium for both moderate to severely active ulcerative colitis and Crohn's patients, remembering that we have IV induction only at this time for ulcerative colitis, but both sub-Q and IV induction options for Crohn's disease, and then 2 maintenance options of monthly or bi-monthly for both ulcerative colitis and Crohn's, showing its efficacy both upfront short-term as well as more long-term. Thank you for listening, and for more educational content, please visit the WRAP website or WRAP ACE app.